Good afternoon, everyone. Thank you for joining us. I'm Krista Droback with Sirona Strategies, joined here by my partner, Kristen, and our colleagues, Chris Adamek and Sarah Sugar. We are going to talk today about what to expect in health policy in 2025. We will move through these slides somewhat quickly because there's a lot to cover. So please ask your questions in the chat, and we will be sure to get to as many as possible. First, a word about Sirona. This is our team, and we have experience across health policy at both levels of government, state and federal. We have a unique approach to lobbying. We use a very integrated tactics. We help our clients with strategic planning, thought leadership. We're constantly monitoring on issues of relevance, looking for opportunities and threats. And we form partnerships across third-party groups in Washington. So generally, we're out there solving problems, and we do also have significant relationships. We also run 5 coalitions. Moving Health Home is aimed at bringing more healthcare into the home. So think of hospital at home, SNP at home, primary care at home. We want patients, mainly seniors, to be able to choose to go home, to recover or to receive primary care. We have Alliance for Connected Care. That coalition has been around for 11 years, working on telehealth and remote patient monitoring. The Health IT Roundtable is a discussion forum for interoperability, AI, TEFCA, all kinds of issues that are happening in health IT. Partnership to Empower Physician-Led Care is working to ensure that physicians are able to engage in value-based care and be at the center of value-based care models. And Aligning for Health is a coalition dedicated to whole person care, integrating food, housing, healthcare, with transportation, et cetera. So any of those, please check out our websites. We're doing significant advocacy in 2025 in all of these areas. So as you've probably read in the news, we are on the precipice of the end of the year. Our funding as the government runs out December 20th. There was a bill released yesterday, has a significant number of provisions in it. Many of the things that the committees have been working on, most of these have, if not all, have gone through regular order in both the House and the Senate, the Finance Committee, Health Committee, Energy and Commerce, Ways and Means. As you know, that is a long process. And lots of stakeholders around town fighting for all of these provisions. We ourselves have worked really hard on a 5-year extension of the acute hospital at home provision, which is hospital at home, and a 2-year extension of the telehealth flexibilities in both Medicare and in the commercial market in high deductible health plans. We have worked on other provisions here, as I'm sure people on this webinar have also too. The legislation, I think the longer it sits out there, the more precarious its position becomes. The House might move up their vote date to today. There are folks on X and Truth Social and other saying that this is a very large bill with sort of a piece of pork. So we're hoping that I think the people who have worked on pieces of this bill are anxious for it to get passed. It does fund the government until March 14th, at which time we will have to come back and do either another continuing resolution or appropriation. So if you have any questions about the end of year legislation, please put it in the chat. Otherwise, we're going to move on to 2025 with the incoming Trump administration. There has been much discussion of Make America Healthy Again. In fact, there is a Heritage Foundation briefing going on today about this. There has not been a lot written, but this is what we have gathered about the plan. It will have a significant focus on chronic disease and the root causes of chronic disease. So we want to essentially tackle the rising costs of healthcare by addressing food and walkable communities and spending time outside and all of the things that we haven't normally focused on when we're thinking about healthcare costs. The the food, there's basically policies in all of these lines and these cross departments. So the agriculture department, the energy department, health, obviously health and human services all have some jurisdiction here. So it does remain to be seen how this will be divided up. But the plan is still coming together and essentially being written down. So we'll be closely monitoring how this comes together across government. The leadership of HHS and CMS have both been chosen. Robert F. Kennedy Jr. and Dr. Oz, they will both be going through confirmation. RFK Jr. has been up on Capitol Hill this week. I think he has met with 25 senators. He has been very focused on chronic disease prevention and eliminating sort of the upstream causes of chronic disease as he sees it. Things like artificial dye in food. He's also very interested in ridding healthcare policymaking of conflicts of interest and expanding U.S. manufacturing of pharmaceuticals. He just met in Mar-a-Lago last week with pharmaceutical executives, and in which they did talk about domestic production. He is a vaccine skeptic and has previously spent a lot of time working on environmental causes and has traditionally been pro-choice. So those are probably some of the areas that he might get questioned during his Senate Finance Committee and Health Committee confirmation hearings. Dr. Oz is a former candidate for the Senate from Pennsylvania and a TV personality. He is very interested in Medicare Advantage, very interested in value-based care and digital health. He's expected to follow traditional priorities, Republican priorities in Medicare and Medicaid. Dr. Jeanette Nishawat is going to be the Surgeon General or the nominee for Surgeon General, and Dr. Dave Weldon for CDC. So the Surgeon General is very much in the sort of lane of thinking about chronic disease and root causes of chronic disease and wellness, as RFK is. And the CDC director has a long history on Capitol Hill, so you can see his many positions. But he is interested in restructuring the CDC and is also interested in more oversight of vaccines. Finally, we have Dr. Marty Makary. He is the nominee for FDA commissioner. He is well known, long time sort of voice of healthcare. He has written a lot. It's it's fairly easy to sort of look up all of his positions. He is interested in restructuring the FDA. There is already a lot written on restructuring at the FDA. So that work has already been underway and will likely continue under Dr. Makary. He is pro-vaccine, but has been a vocal critic of the COVID vaccine effort. So we do expect that abortion will be a focus, specifically on mifepristone under Dr. Makary. And then finally, Stephen Miller, who is going to be the head of policy at the White House. He is most interested in immigration and other sort of homeland security issues, but he will have the final say on healthcare in the White House. We don't yet know who will be at the top of Medicare or the top of Medicaid. Obviously, they'll be reporting to Dr. Oz. Lots of names have been floated. John Brooks has been named to the landing team at HHS, but we're obviously keeping a close eye on who those folks are. They will have a big impact on Medicare and Medicaid. You have also probably heard about DOGE. It is a non-governmental agency that will make recommendations to Congress and Capitol Hill and the Trump administration. There are going to be people embedded in the Trump administration who will be coordinating with DOGE. Those people have already started to be identified for HHS. So they will be working internally to take the DOGE recommendations and figure out how they can use the levers of regulation to implement those recommendations. And to the extent that they don't have authority, DOJ has caucuses in both the House and the Senate. In fact, in the House, they have an actual committee, DOJ committee, where they will be writing legislation to implement the DOJ recommendations that they, obviously the ones that they want to. So even though they're a non-governmental agency, they will have a big role and a lot of power in the Trump administration. They are very transparent about what they want to do. You can follow them on X or Truth Social. They also are going to be hosting a Dogecast where they're going to be keeping the public up to date. They're very committed to transparency. So it is not going to be too difficult to find out the areas that they are interested in cutting and making recommendations to the Trump administration and to Capitol Hill. I'm going to go ahead and turn it over to my colleague, Chris Adamek, to talk about the congressional landscape.
Hello. So I'm just going to provide a very high-level view of the congressional landscape here. We're going to talk about a little bit more on policy slides further in. But just want to start by saying with one party in control of both houses, we have a significant opportunity for movement. We're going to see Republicans move quickly to advance a number of policy priorities that they otherwise would have been stymied in moving with Democrats in control of at least one chamber or the presidency. With regard to leadership, want to flag that Majority Leader Thune has a long healthcare record, but we expect not going to be able to focus very much on that and in his role as Majority Leader, just given his many responsibilities in moving forward the Senate. Do want to flag, I think there's a lot of interesting activity that's going to happen with the Help Committee with Senator Cassidy taking over the chairmanship. As many of you know, Senator Cassidy is famously intellectually curious, has a wide range of issues that he is engaged in and wants to work on. And I think we're going to see quite a bit of activity from Help across a lot of issues that we care about. Senator Crapo taking over the Senate Finance Committee, a role that he's had before. I think we're going to see finance get very caught up in tax reform. We will have a lot of tax-related issues before finance this year, and that's going to lessen the bandwidth for some of the healthcare priorities that we would traditionally see. That said, want to flag that Chairman Crapo and current Chairman Wyden have worked in a bipartisan way on many of these issues over the past few Congresses. So there are a number of work streams that will continue. Their work on mental health, their work on oversight in a number of areas, including PBMs, Medicaid, et cetera. We'll see some of that stuff continue. We have a changing of the guard at E&C. However, these are with members, Rep. Guthrie and Rep. Carter, who have long been active leaders on healthcare issues in the committee. And so we'll see a little bit of change in the committee, but I think a lot of it will continue to focus on issues that we've been engaged in, the committee has been working on moving forward. And Ways and Means will continue with Chairman Smith, so a little bit less change there. Next slide. And then just thinking about how 2025 unfolds for all of us, we're going to see a big chunk of the early part of the year taken up with Senate confirmation hearings. As you remember, many of these candidates are in some way a little bit controversial. We'll have quite a bit of back and forth around them. We'll have many hearings. This always goes slower than we think it's going to, or that the incoming administration thinks it's going to. And so just anticipate that causing barriers for some of the legislative priorities that we'd like to see as the Senate gets wrapped up in this work. Another important forthcoming item here, so we will have a debt ceiling renewal necessary. And as Krista mentioned at the top of this call, it looks like we're going to need to fund the federal government in March. I wouldn't expect that to be any easier of a process in March than it has been here on a bipartisan basis, given that there are many in the Republican caucus who will have strong feelings about government funding. And so I do expect that will be a pretty significant effort that takes quite a bit of legislating to move forward. Another thing on the plate for this next year is reconciliation. So we have two reconciliation opportunities. We're going to talk about reconciliation a little bit more further on in the slides, but work has already begun on what it is that we can move in a reconciliation package. The biggest issue is, of course, extending the Trump tax cuts. But I think a number of other issues can fit into reconciliation, and Republicans will be working to advance one or two vehicles to drive reconciliation forward in 2025. From a landscape perspective, generally we see much less bipartisan activity happen in Congress when a reconciliation vehicle is moving, given that it is a partisan exercise. And so that's something that we'll also want to keep in mind for bipartisan work that we want to see move forward, or efforts where we need both Democrats and Republicans to be engaged in leading on an issue. We also have an opportunity for Congressional Review Act of key regulations, and so Congress can pull back regulations from the last 60 legislative days if they would like to cancel them. That is something that we will probably see used early in this administration in Congress. Right now, the House is working on a bill that would allow them to repeal regulations en masse instead of doing it individually. We've yet to see if that will be something that moves forward and passes, but there is quite a bit of thought on that. That would also be a way for a Republican Congress to repeal some popular Biden administration regulations that they otherwise wouldn't be able to move on a item by item basis. Krista already mentioned DOGE. We will see quite a few recommendations come from DOGE and go to Congress, and those will take up some congressional bandwidth as we are thinking about how to incorporate those in the legislative process. And then finally, want to flag another dynamic here is post-Loper Bright. We're in a world where Congress will feel the need to put more detail into statute. So we will be working to provide really clear instructions to the agencies, given that they will now have less autonomy to interpret statute on their own. And so that does mean that it adds a layer of complexity to legislation that we're drafting, because the past world where we could just say, send this to the agency and have them do it, is something that's going to be much more difficult now, or far less likely. And so we're going to have a lot more detail written into statute. And then I'm going to turn it back to Krista.
We just put this slide in here to put a finer point on the length of time that it takes to confirm all of the nominees. CDC is, for the first time ever, going to have Senate confirmation. And obviously there's lots of diverging views about the future of the CDC. So if you think about it, the staff on the Health and Finance Committee, as well as the two committees of jurisdiction in the House, only have so much bandwidth. And if they're preparing their bosses for, in the Senate for the confirmations, this slows them down on legislating, which does offer the question of, what kind of legislation could we actually pass in March versus another CR or picking up, something from last year. So this is just to kind of show you how much work is going to go into these confirmation processes. So on to reconciliation, you will hear a lot of discussion of reconciliation. We can do one reconciliation bill per fiscal year. And since we did not pass a budget in 2025, the incoming Republicans have an opportunity for a reconciliation package in 2025 and 26. The first, and there still is some disagreement about whether they're going to do two, but for purposes of this slide, I'll just talk about the opportunity, or the option for two. The first would be on border security, energy, and defense. And the second would be on taxes and healthcare. Each process is very complex. The budget resolutions have to be passed in the two budget committees. They have to be reconciled. They do not have to be signed by the president, but they do have to be reconciled between the two chambers. And then once that happens, instructions are sent to all of the committees. So all the committees are going to be working on their budget reconciliation instructions, and they can't include policy that does not have a budget impact. So the Senate parliamentarian will be very busy determining whether certain policies have budget impact or not. There could be some interesting and creative ways that things are written to create a budget impact. And so Some of those will have to be deliberated with the parliamentarian, but essentially then the committees come back together. Everything comes back together in a reconciliation package that then passes the chamber, which is also not easy, and then has to be reconciled. So we're going to go through that potentially twice. And I think, some part of the debate is, number one, let's not have two votes on two different bills that could have controversial things in it. Let's just have one vote. And also just like, how are we going to get two of these processes done in 1 year? It's a pretty tough thing to do. So in reconciliation, in the second, if we do two, the second one will be focused on healthcare. We will likely see some reform of the Inflation Reduction Act. That was the bill that established Medicare negotiation of prescription drugs, some form of Medicaid reform. There is a debate about the ACA premium subsidies. They expire at the end of next year, so we could just not renew them, or we could have some reduction of those subsidies going forward. That is not going to be something it's going to be cost the government money, because we're renewing the subsidies rather than cutting them. There could be more on health savings account policies, site neutral payment, and NIH reform. There is significant money that goes into NIH every year, and there's a lot of skepticism among incoming leadership that we should be spending as much on NIH. There's also been a previous proposal to reduce the number of agencies within NIH. So there could be NIH reform as part of reconciliation. I just want to mention, for those of you who don't, dwell in the Washington space, you will hear things like savings and offsets, as well as a baseline. So the baseline is current law, and the Congressional Budget Office scores bills based on what the baseline says. So they can score something as a savings, and then that savings can be used as an offset for some other priority that we're interested in. So there are a lot of priorities for the coming year, not just in healthcare, but also in, extending the Trump tax cuts. And so we are going to need to find offsets. And healthcare is a big opportunity for offsets. The incoming leadership has said they won't touch Medicare or Social Security, but that still leaves a lot of, NIH and Medicaid, for example. So you will hear these things thrown around. One thing to think about is, as the Trump administration, is interested in rolling back regulations, sometimes it's better for Congress to do it, because you can take those savings. So the mental health parity rule is a good example that was finalized this year. It is expected to be rolled back, but the Congressional Budget Office has estimated that rolling it back will save $1.6 billion. So it's sort of, the theory goes, why not have Congress do it so they can take that $1.6 billion and put it towards some other priority, where if the Trump administration does it, it becomes part of the baseline. So you can't actually capture those savings. So that's just a distinction in thinking about how some of the Biden era policies are going to be rolled back. So the Congressional Budget Office just this week came out with a refreshed list of ways that we can save money in healthcare. Some of these things have been around a long time. There are 3 new ones. A site neutral payment is a new one that is basically paying hospitals, you don't pay hospitals in a hospital rate at off-campus settings. It's been around for a while, but CBO put it on its list. The 340B savings idea is new, and there's a couple other here. I think they're starred. The enrollment fees in TRICARE. There's some pretty big ones here, as you'll see. Any kind of caps, per capita cap, or block grants. Medicaid has quite a bit of savings. Limiting provider taxes in Medicaid, also big savings. So I would take this list pretty seriously, given the numbers that we're looking at for next year in terms of needed offsets. In the past, these have been thought of as like pretty big disruptive policies to undertake. But given that we are in a disruptive time and we need some pretty big offsets, I would, take this list pretty seriously. So I am going to turn over to my partner, Kristen McGovern.
Thanks, Krista. So this section of the deck, now that we've talked a little bit about the end of the year and the congressional outlook, we're going to do a little bit of a deeper dive into specific policy areas and what we're expecting the landscape will be on those policy areas. So I will talk briefly about Medicare and then turn it over to Krista to say a little bit about Medicaid. I know there have been a couple questions about Medicaid in the Q&A. So if we do not answer your questions during that slide, please feel free to type in and ask for additional specifics. We will then move past those slides to additional issue areas like behavioral health, drug pricing, value-based care, health IT, AI. And again, please feel free to put your questions as you have been in the Q&A bucket if we don't answer them. So in terms of Medicare, Krista already mentioned that there have been, in terms of the incoming personnel, that some guardrails have been put around, Medicare cuts in terms of what would be on the table. We have seen Congress over the last year in sort of the early stages of considering reforms to physician pay and the MACRA legislation, which is meant to be a framework that replaced the sustainable growth rate several years ago and is supposed to reward and pay physicians based on their performance on certain metrics like quality, cost, clinical practice improvement, and use of health IT. There have been numerous stakeholders that have indicated that the framework that was put in place under MACRA is not incentivizing or does not provide strong enough incentives to encourage providers to do the things that we want them to do. And so there has been bipartisan conversations around either alternative frameworks or changes that could be made to the current framework to create stronger incentives to begin to do population health activities and other types of things that would set providers up to sort of move along the fee-for-service continuum into accountable care relationships. So we expect that those conversations will continue. The end-of-year package does include, sort of additional money to blunt the cuts that physicians would otherwise feel under Part B. But it is not a reform. It does not include reform, and we expect that there will continue to be work along those lines next year. We also expect that Congress may consider site-neutral payments, potentially even in the reconciliation packages that Krista mentioned. These are of interest to the Trump administration, and we have even, I think, over the last year or so, picked up some Democratic support on site-neutral payment issues. But certainly as we move into a session where we have Republican-controlled Congress and a Trump administration, more likely to push the envelope with respect to site-neutral payments, particularly in light of all of the savings that can be generated in the form of offsets, as Krista sort of mentioned earlier. We also expect that calls for Medicare Advantage, policies related to Medicare Advantage will continue. So Congress is currently, aware of and engaged in policy discussion related to Medicare Advantage risk adjustment in light of the series of Wall Street Journal articles that ran over the summer and ongoing drumbeat of HHS OIG reports. Prior authorization reform discussions will continue on into 2025. They were one of the last minute hangups on the end of year package that was released this week. There were two different approaches that were being discussed, and ultimately they just didn't go with either approach. So that's sort of still on the table for discussion next year. So we expect, in terms of Medicare, for some of the efforts, the policymaking efforts that have been sort of in the earlier, more nascent stages to continue on into the next session. With respect to the administration, we expect that the incoming Trump administration and the personnel that Krista highlighted earlier will really focus on chronic disease and preventable disease in the Medicare program. There have been reports that Robert Kennedy Jr. is interested in reforming the Medicare payment system and sort of moving away from the reliance on the AMA's RUC for valuing codes, and potentially, concern about the time-based system and somehow coming up with a different metric upon which providers can be reimbursed. very few details. Obviously, that would be a large scale undertaking over the course of many years. So very few details about what that would look like or where they might want to start. But we expect that some of those additional information about that could be made available even as soon as the confirmation hearing. We also expect that there will be interest in large-scale reforms to quality. So incoming administration officials have indicated that, they are concerned about quality measures that are sort of check the box exercise that add administrative burden to Medicare providers' plates, and also concern about metrics that rely on pharmaceutical interventions. So, measuring blood pressure control by, rate of prescribing of a statin, for example, would be a metric that the incoming administration, might want to take a second look at. They are very much more focused on patient outcomes. So we are likely to see sort of a doubling down or a renewed focus on patient-reported outcomes measures and other outcomes-based types of approaches to measuring quality. We do expect, and this is the last thing I'll say before we go to the Medicaid slide, we do expect that the incoming administration will be a very pro-Medicare Advantage. Dr. Oz in particular is on record as being very supportive of Medicare Advantage for all. We expect that they may, will do what they can to remove barriers to Medicare Advantage enrollment, may consider approaches to making Medicare Advantage the default Medicare option, and in terms of new to Medicare signups and patients. We also expect that they might remove barriers to marketing and or do other types of things that would make it easier for patients to enroll in Medicare Advantage. One thing I did want to mention is that the Biden administration recently proposed a rule that would require coverage of obesity drugs, so GLP-1s for patients with obesity. And some of the folks that are aligned with the incoming personnel have indicated that this proposal should not be moved forward with, and have expressed concern with, again, sort of along the lines of, what they've said in other areas, but have expressed concerns with pharmaceutical interventions rather than treating the underlying causes of obesity. So that is going to be a sort of a lightning rod issue that is out there as proposed right now, and that the Trump administration would need to take early action on if they want to pull that back. Krista, turning it over to you on Medicaid.
So the philosophy of the incoming leadership is emphasis on efficiency, self-sufficiency, reducing waste and fraud, and empowering patients. So some of the policies that we expect to see on Medicaid are work requirements. So that goes to the self-sufficiency argument. I personally believe that it is going to be hard to do work requirements the way we did it last time through 1115 waivers. The Biden administration has been throwing up some roadblocks to this. They just issued an advisory opinion, the HHS did last week, basically saying that it is not legal to include work requirements in Medicaid. I also expect that there will be immediate Loper-Bright challenges, saying that the CMS doesn't have authority to add work requirements. So I think it's more likely that we will see work requirements in as part of the reconciliation package. Chairman Crapo of the Finance Committee has said that that he's interested in work requirements. So expect to see those. I likely think that they will be more successful at being added to Medicaid through a legislative process. Per capita caps, we saw these in 2017 in the passage of the BICRA. It was called back then essentially the repeal of Obamacare. It passed the House, lots of Senate votes for it. Essentially, it divides Medicaid into 4 beneficiary categories, sets a benchmark for those categories, and then pays states based on the benchmark and is indexed to the Consumer Price Index, which is lower than the medical index. And so it would essentially sort of reduce the amount of payment to states over time. It's also pretty hard to reflect Medicaid payments in the cyclical nature of Medicaid. Obviously, there's a lot more enrollment in Medicaid during economic downtimes. But this, this proposal is out there. We have dusted it off and then been looking at it again. Similarly, lifetime caps are being contemplated. So people who go in and out of Medicaid would have a lifetime cap on their sort of eligibility for Medicaid. And then there is already discussion about supplemental payments in Medicaid, provider taxes in particular. 39, all states have provider taxes. It's sort of like it's kind of a scheme, but it has also grown up as a foundational way to fund Medicaid programs. It allows Medicaid, it allows states to tax providers and health plans up to 6% of the program, use that money to draw down the federal match, and then redistribute that funding to the providers of healthcare, to Medicaid beneficiaries. As I mentioned, all 50 states have provider taxes. 39 states have more than 3 provider taxes. It's been a long time discussion within the Republican Party. Tommy Thompson, when he was secretary under the first Bush administration, was up on the Hill talking about provider taxes and intergovernmental transfers. So I expect to see that come back. It is about a $60 billion cut in Medicaid every year. It can be done administratively. Obviously, we think that Congress will want to use those savings. So it probably will appear in legislation. It doesn't necessarily have to be completely eliminated. There are ways to dial it up or down. You could reduce the 6% to 5%, for example. So, it will probably be on the table as a topic of discussion, but not necessarily like full elimination, but that would save a lot of money over time. So keep an eye out for Medicaid changes in 2025. Back to Kristen.
Okay, so with respect to health IT, we have seen the Biden administration really take an aggressive approach, particularly with respect to implementation and furtherance of the Trusted Exchange Framework and Common Agreement, which is a nationwide health information exchange network launched by the Biden administration. I think under an incoming Trump administration, there will be a focus on AI, as we talk about in the next slide. But there is a big question mark here in terms of how aggressively and whether a Trump administration will pursue many of the Biden administration's health IT policies. So with respect to information blocking, which is a regulatory framework that includes penalties for providers, health information networks, health information exchanges, and certified health IT developers who do not share a requested health information under certain circumstances, we expect that we will see the Trump administration begin to enforce information blocking regulations. So the Biden administration really put the framework in place to sort of outline the rules of the road, but they have not yet begun to enforce any of those rules, and we expect that a Trump administration will do so. We have also seen some late-breaking rulemaking from the Biden administration related to some proposals that they previously put out earlier this summer related to the capabilities that they wanted to regulate in certified electronic health records, as well as with respect to TEFCA and the information blocking regulations. We have seen in the past few days 2 final rules coming from the Biden administration. Their proposals were very broad and sweeping. So recognizing that they are short on time, what they have done is pull out specific pieces of their proposed rule into 2 new final rules. So there are some proposals that remain on the table for the Trump administration to do something with if they choose. And then there are some proposals that have been finalized. The first rule, which they're calling the HTI-2 final rule, codified provisions related to TEFCA. And the second final rule, which they are calling the HTI-3 rule, codified proposals related to information blocking that would give special protections to regulated entities that do not share reproductive health information under certain circumstances. The HTI-3 final rule related to reproductive health data will be politically interesting to the incoming Trump administration, and it will be something that the Trump administration will likely decide to either pull back through rulemaking or to work with Congress to get the rule pulled back. So that is something to watch there. And interestingly, although many of these health IT proposals are bipartisan, it really does put the Assistant Secretary for Technology Policy, the office who put out these policies, sort of into the political limelight in a way that they are not normally accustomed to. So with respect to TEFCA, I mentioned that this is an area where the Biden administration has been sort of aggressive in a way that has not been characteristic of the rest of their policymaking. And I think a Trump administration would be expected to perhaps not pursue implementation of this network as aggressively and or to adopt a wait and see approach and sort of see how things play out. With respect to privacy, the Biden administration did finalize a rule increasing HIPAA protections for some reproductive health data. We expect that will be challenged legally imminently, and that a Trump administration would decide whether to repeal or exercise enforcement discretion while the anticipated legal challenges play out. So that is also on the radar. One other thing to mention is that the first Trump administration did also put out a proposed HIPAA rule on coordinated care that was never finalized by the Biden administration. So that would be something in the realm of privacy we would be looking to see if a second Trump administration takes up again. We do expect that the Office of Civil Rights at HHS, which is the office that enforces both the HIPAA privacy and security rules, will also prioritize other work that is in their portfolio, including potentially a rewrite of the Section 1557 anti-discrimination regulations and cybersecurity. And so there's a lot going on in this bucket that could be considered for the future. The next slide touches on AI specifically, and we wanted to call this out specifically because it is a sort of its own discrete bucket of work. When the Office of the National Coordinator reorganized into the Assistant Secretary for Technology Policy, the HHS Chief AI Officer came under the purview of that office. The Trump administration has named David Sachs as the White House Chief Advisor on AI and cryptocurrency. He will also lead the Presidential Council of Advisors for Science and Technology, or PCAST. We have seen some early remarks from the Trump administration or the incoming Trump administration in terms of how they're going to think about AI. It seems likely that President-elect Trump will repeal some of the standing executive orders on AI from the Biden administration and will not adopt the existing AI Bill of Rights developed by the Biden administration. We expect that the incoming Trump administration will put in place a new executive order and will focus on AI for national security and defense purposes. They are also likely to move away from some of the principles around the use and implementation and development of AI that focus on things like fairness, equity, anti-discrimination, and instead focus on other frameworks for the appropriate use of AI. In terms of Congress, we saw the House bipartisan task force on AI release a roadmap this week that follows on a Senate roadmap that had been previously released. The Biden administration is still planning to release their federal AI strategic plan. So it remains to be seen whether the Trump administration would take that up. And we do expect there were a couple bills here that are noted on the slide that were in the mix in the early days of the end of year package discussions. And so these bills would codify certain pilots that are already underway, the National AI Information Resource Center, and then the AI Safety Institute. And so we do expect they are bipartisan. Again, we're on the table in the early days of the end of year talks, and we expect that those bills in particular might be reintroduced next year and up for consideration. So that is it on AI, and I'm going to turn it over now to Chris to talk about behavioral health.
So on behavioral health, I want to start by emphasizing that the Trump administration comes in building on a pretty significant legacy in behavioral health space. In the past administration, we did 988 implementation. We declared an opioid crisis public health emergency. We expanded funding for community behavioral health centers. We passed the Support Act, lots of provisions there. We had dedicated efforts on mental health and suicide. Many of these efforts were supported by executive orders from the administration where President Trump himself was engaged in that work. So notable to have this as a background. This being said, a little bit of a challenging period for behavioral health access. I think we're going to see cuts to SAMHSA funding. The FY21 proposal from the Trump administration had cut SAMHSA in its final year. We also have DOGE and others looking for places to cut the federal government. Krista already talked about Medicaid funding, both significant funding streams that support mental health access that we expect to see contract in the next year or so. Also expect to see the Biden administration's mental health parity rule pulled back. There are a number of avenues it could happen through, either administratively, or we could see the Congressional Review Act used, as Krista mentioned, probably more likely if it's done as a group exercise, but do see that pulling back. I do think that creates a void where there is additional opportunity to talk about mental health access. While we did just talk about some provider directory restrictions or requirements that were in the end of year proposal, I don't think the conversation around ghost networks and access to behavioral health providers is over. And so if parity gets pulled back, I do think that we still have a pretty robust conversation around access. If it's not a parity regulation, what is it, and how do we ensure patients have access to mental health? Also want to talk about the DEA telemedicine rulemaking. So we got a year-long extension from the Biden administration last month, and that is the regulation that allows the prescribing of controlled substances through telemedicine. Very important to much behavioral health care. The Biden administration is going to still put out a proposal this month. That proposal will likely not be fully adopted by the Trump administration. However, they do have a year to move something forward, and so do think that the DEA and HHS and the Trump administration will need to be working on this issue and finding a balance between patient access and preventing diversion of controlled substances. And so that'll be a major area of work in the following year. And something that doesn't require additional policy work, but is a notable change, is starting in January, we will have permanent audio-only telehealth in Medicare. That is a big deal for mental health access. So much mental health does rely on audio-only services. Do you think that creates an opportunity for many organizations to expand care and build their business models, knowing that there is kind of a permanent path forward for that care rather than a temporary pandemic flexibility that's continuing? And as I touched on here, Krista talked at the beginning, we did get Support Act extension, or are poised to get Support Act extension in an end-of-year package. We also got the Medicare Advantage provider directory language that was largely focused on mental health into that end-of-year package, but I don't think that those are the end-all be-all, and I do think there will be some opportunities to move forward a little bit more on this. We can back to Kristen.
I think Sarah is going to do value-based care.
Thanks, Chris. We are expecting continued support for value-based care under the incoming Trump administration. We have seen support for growing value-based care in the past several administrations, regardless of party affiliation, but we do expect a different approach to the Biden administration's value-based care goals and strategy. The Biden administration has been very focused on growing accountable care relationships, which they define as relationships with Medicare beneficiaries and their providers, in which their providers are accountable for quality and total cost of care. They have had a major priority in embedding health equity and addressing underserved populations in all of their models. Several of their models include fairly robust health equity requirements, including data reporting, developing health equity plans, in some instances embedding health equity adjustments into the financial components, such as risk adjustment of the models. And we do expect the Trump administration to take a different approach and revert back to more of a focus on two-sided risk arrangements, which was the focus of the first Trump administration. They had set a goal of growing two-sided risk arrangements in both the traditional Medicare and Medicare Advantage populations. And so given that, we do think it's possible that some of the more recently announced Biden administration models, specifically those that are focused, that don't include risk-based arrangement and have a heavy focus on health equity, to potentially be terminated or at least substantially altered. And as has been mentioned, we are still awaiting leadership for CMS and the Innovation Center, which will obviously have a big impact on the priorities and objectives of the value-based care goals of the administration. But we do expect priorities to include growing accountable care organization innovations. So the first Trump administration announced the geographic direct contracting model, which was ultimately walked back, but we do think it's possible that that model is resurfaced. The first Trump administration was also developed the global and professional direct contracting model, which was the predecessor to the ACO REACH model. So we do expect a continued focus on ACOs and direct contracting models. We also expect a focus on condition-specific models with the goal of bringing more specialists into accountable care arrangements, as well as Medicare Advantage models. As has been mentioned, we expect the Trump administration to have a very big emphasis on strengthening Medicare Advantage. And there are several ideas in the Republican orbit already, such as in inferred risk adjustment model, which would take an inference-based approach to developing risk scores, and the Medicare Advantage qualifying incentive demonstration, or MACWI demo, which would have exempted certain clinicians who engage in a lot of Medicare Advantage payment arrangements from reporting MIPS requirements. On the congressional side, we do expect continued support for some reforms to the Innovation Center. There has been legislation in the past several years that has been reintroduced that would streamline the Innovation Center's evaluation process and increase transparency and opportunities for notice and comment. And we do expect that to continue in the next Congress. And go ahead to the next slide, Krista.
I think this is the last slide before we are going to answer some questions.
Yes, so I can go through this quickly so we have time for questions. We do expect continued focus on prescription drug pricing reforms in the next administration, as was a major focus under the first Trump administration. PBM reform remains a very hot topic, although it is looking like we are going to have some fairly significant reforms included in the end-of-year package for both Medicaid and Medicare. That includes banning spread pricing in Medicaid, and Medicare reforms that would delink reimbursement of PBMs from the list price of drugs, and other Part D contracting reforms. And so if that does cross the finish line, which it's looking like it will, then PBMs will continue to get attention in Congress, especially considering the leadership of several of the committees of jurisdiction have key priorities around pharmacies and PBMs, although we do expect a little bit of a shifted focus likely to the Inflation Reduction Act, just given all of the activity that has happened this year. Congressional Republicans are obviously very eager to repeal certain provisions of the IRA, namely the Medicare drug price negotiation and Part D stabilization program. This will also be a priority for the administration, although until Congress acts, the administration will be required, at least to a certain extent, to continue action on the IRA. By February 1, the next list of Part D drugs for negotiation is statutorily required to be released. It's possible the Biden administration acts on that, but the Trump administration will have to, continue down this path until we see legislation. Although the one outlying variable here is litigation. There are several lawsuits right now around the Medicare drug price negotiation program. It is possible some of these lawsuits will end up at the Supreme Court. And while the Biden administration has obviously been defending the program, the Trump administration is likely to take a different approach. So that is another variable in the future of the IRA. Trump may also revive his most favored nations policy, which would tie the price of drugs we pay here to those in other countries, although there's been some conflicting messaging as to how high of a priority that would be. And then the last thing I'll just quickly note, the 340B program. That has been a particular focus of Senator Cassidy, who will be the chair of the Senate Help Committee next year. There's interest in potential reforms to that program at a minimum to increase transparency. So we think that that will continue to get attention in Congress next year.
Sarah, one question as we transition to our Q&A, there's one question here on drug pricing. Could you elaborate on the prohibition on spread pricing?
Yeah, so spread pricing occurs when PBMs retain a portion of the amount paid to them for their prescription drugs. So this provision, if included, if passed at the end of year package, as it looks like it will, would ban that practice specifically in Medicaid.
Great. Krista, on the topic of Medicaid, a question here about the potential for public charge to resurface.
Everything is on the table. I think it will. I think we're all dusting off our files, and I would recommend that everyone do the same. Or, talk to us if you're interested in answers. But I think everything is really on the table here for this coming administration. They are much more prepared than they were in 2016. They've been working over the last 4 years on things that they want to do. Encourage you to read Project 2025. Definitely read Paragon Institute papers. It's all pretty much laid out for the goals of this coming administration, and there will be significant disruption. So I do think that we should be prepared for everything.
Okay, next question for you. Do you foresee any impact on the home health care sector and separately the home attendant care sector for Medicaid enrollees over the age of 65?
I think that
The
first focus in 2020, first, there is some HCBS language in the end of year package. So, take a look at that. But the areas of focus, I think, are really going to be on where there can be reductions in funding and where the federal government can shift costs to the state. So the discussions that we're going to have in 2025 are going to be big overarching funding discussions. I think, a lot of it also does depend on who they choose for Medicaid. I don't expect that to be, I don't think that person is probably going to come in to the agency until like May. So, those things take a long time. And so, I think HCBS is bipartisan. Expect a big emphasis on perm. There's going to be, sort of a waste, fraud, and abuse discussion happening. So I think basically, look at the perm rates and, and focus on larger cut issues rather than just on HCBS in this first year.
Okay, and then the last question here, which I will take very briefly because I know we are at time. Oh, we've got another one, but I will answer this AI question. More details or context for AI efforts now versus incoming administration. So the AI discussion is proceeding on 2 planes, one of which is how can HHS and other federal agencies use AI to make their operations more efficient. The other of which is how is AI being used and deployed more broadly in the healthcare landscape. The Biden administration has taken a conservative approach on the latter set of issues and in terms of how AI is being used more broadly in the healthcare system. We've seen them release a couple FAQs on how it can be used for coverage or should or should not be used for coverage. And they have been concerned particularly around the discriminatory use of AI. I think as we move into a Trump administration, we are going to be much more focused on AI as a cybersecurity a deterrent, but also AI as a cybersecurity threat. So we are going to be looking at AI less in terms of a coverage lens and discrimination lens and more of a national security and defense lens. And that was just a very brief discussion. There's a lot more under the hood here, which I am happy to follow up with if you send me your question. I know we have a couple more questions that came in here. We are out of time. We will try to follow up with you separately on some of these. It looks like we've got a question about immigration policy and deportations affecting HCBS workforce, and then a question on the implementation of the Medicaid access rule, specifically the 80/20 We will try to take those as follow-ups. We will be distributing the slides here, and
As well as the recording.
right.
It'll be on our website.
Yep. So we will make sure that you have those resources. Thank you for joining. I hope
Thank
everybody has a
you.
happy holiday season. Talk to you soon.
Happy holidays. Thank you, everybody. Okay, I'm here.